It was not, this charge was not supposed to be a charge.
from Johannesburg. Thank you very much for joining us. In our top story, the Northwest Health Department says a patient who sparked an Ebola scare in Potchefstroom has been transferred to the Klerksdorp Tsepang Hospital. Let's talk to the department to find out what the status is of this gentleman. We understand he is a 72-year-old man and he was treated in isolation at the Potchefstroom Hospital. Good morning and thank you very much for talking to us this morning. Tebogo Legetwane, who is the spokesperson of the Northwest Health Department. Tebogo, can you confirm that the gentleman quarantined earlier at Potchefstroom Hospital is definitely not suffering from Ebola?
We can confirm that, ma'am. At the moment, indeed, the patient has been transferred to Klerksdorp in a very stable condition. Klerksdorp is our designated isolation center in the province, and we're going to continue to run some tests today. Hopefully, we will know by midnight what the condition is, because as we had indicated, the patient presented with high fever, weakness, and cough. Then the symptoms that we saw was that of hemorrhagic fever. And we will know immediately after the tests come out what is the disease. But we are excluding Ebola because the patient has not traveled any way abroad and has not been in contact with anyone who comes from outside of South Africa. We know for a fact that this patient is a local patient, member of the community in the farming communities near Potchefstroom. That is what we know thus far. I can also say that Potchefstroom Hospital, we have uplifted the quarantine there immediately after the patient was transferred to Klerksdorp Hospital.
Let's just get some clarity on this hemorrhagic fever issue. We know that the term is a sort of umbrella definition that refers to a number of diseases that fall underneath the wider umbrella of hemorrhagic fever. We know that dengue fever, the Marburg virus, Rift Valley fever are among those that fall under that definition. I mean, are you able to say, even though he has operated locally and not been exposed to anyone traveling, are you able to say which of these he's likely to be suffering from?
Yes, there are different types of fevers that we know of, and we still maintain that the only way of getting, in particular Ebola, is through contact, as explained by National Department of Health various times. And when we look at this patient, we looked at the background. Where has the patient been? Who has he been in contact with? And it's very clear to us that there could be other things that we don't know. That is why we are running tests. And that is why we are saying to people, the chances of us talking about Ebola are very slim.
Was this patient in any position to pinpoint the source of his exposure to the fever?
Come again?
Well, was he in any position to pinpoint the possible source of his exposure to this illness?
I'm really struggling to hear you, but we don't know yet in terms of how could the patient be able to be in contact or to have this kind of fever.
Well, are you investigating the possibility that he might have already passed the disease on to others he came into contact with at home or work?
We are busy with that investigation, but also at Potchefstroom, where he was, we have ensured that we have disinfected all the medical facilities and the staff that he was in contact with. They will also be put under close monitoring to check if there are any signs that will be presenting similar to those that he has. Equally, we will continue to check with the family where he comes from if there are any signs. At this moment, we don't have any indication of that sort.
Do you have any idea when you will have the results of the medical tests you've carried out on him?
I spoke with the hospital in about 5 minutes ago, and the indication is that we would have result by midnight today.
All right. Thank you very much for talking to us. Tebego Legtwana is spokesperson of the Northwest Health Department.
The dog of a Spanish nurse infected with Ebola in Madrid was put to sleep by health authorities who feared it could spread the deadly disease. This is despite a campaign to spare him by animal rights activists. 2 people were injured when police carried activists away from the entrance to the house. Teresa Romero became infected after treating 2 Spanish missionaries who died after returning from West Africa. In Sierra Leone, striking burial teams have gone back to work. They were threatening to leave bodies littered on the streets if they were not paid.
They are doing a voluntary job. They are not get paid for the job they're doing. They are only given risk allowance, which is a weekly $100, which is, from the political point of view, is a small amount of money for the kind of job they are doing. But we have reassured them that they are going to have their risk allowance. We have appealed to them to go back to work.
Australia is anxiously waiting for the blood test of a nurse who is suspected to have Ebola. The nurse was a volunteer with the Red Cross in West Africa, treating patients with the deadly virus.
She came back into the country. She was perfectly well at that time. She did not have any symptoms. She did not have a fever. So it's only since this morning that she's had a low-grade fever. She has not been out in the community in Cairns. She's been at home, isolated in her own home, testing herself.
Close to 4,000 people are now infected with the virus in West Africa.
Then we have a hood that's going to go on. So the purpose of the gear is once again to make sure that every piece of skin is covered.
It's a long, tricky process, and just one tiny mistake could be fatal. Putting on PPE or personal protective equipment is a crucial part of preparing to operate safely in the Ebola wards of West Africa. And it's also a crucial part of the new 3-day training course developed by the US Centers for Disease Control and Prevention, or CDC. These 36 or so men and women, a mixture of military personnel and voluntary medical staff, are all about to head out to Liberia, Sierra Leone and Guinea in West Africa.
We are really emphasizing the practical hands-on activities that you see behind me. People are putting on protective equipment every day of the course. They're doing a simulated patient care activity every day, and then they're taking off their protective equipment.
This course is hard work, but the CDC recommends that it be just one part of these medics' training before they head to West Africa. Once they're there, it says they should have more in-country mentorship before they use their skills on real Ebola patients. For the participants, despite the harsh realities they're facing, these 3 days of training at a federal facility in Alabama are reassuring and inspiring.
I think with proper care we can get the mortality rate down to maybe 30%, and that's what I'm hoping for, because I'm not going over there to carry body bags. I'm over there to help and to give them the best shot possible.
And for others, it's a springboard to spread the word about setting up Ebola treatment units where it matters most, their home.
I think this will be very good for me going back home. I can use it to train others. Now, if you know, the United States is sending over 3,000 to 4,000 military people who are going to be putting up these units, but I think we also need to know something about how these units work.
For now, the fluids these trainees are dealing with aren't real, but they soon will be. And the CDC says it will run this course for as long as it's needed, hoping the skills medics learn here can eventually help clean up West Africa's Ebola epidemic. Lorna Shattuck, Anniston, Alabama.
In Dallas in the US, a deputy with the county sheriff's office has been hospitalized after falling ill. He was in the same apartment where Ebola victim Thomas Duncan was staying before he died. Officials say the chances that he too has contracted the virus are very low.
It's the signs the CDC puts out of Ebola, which you have nausea, vomiting, headache, some fever, diarrhea. I would indicate that this patient was not experiencing all of those symptoms, just a few.
In Australia, health officials have confirmed tests are being carried out on a 57-year-old nurse who recently returned from Sierra Leone. She had been volunteering with the Red Cross, treating patients diagnosed with the deadly virus.
It's only since this morning that she's had a low-grade fever. She has not been out in the community in Cairns. She's been at home, isolated in her own home, testing herself.
In Spain, police had to force away animal rights activists protesting outside the home of a Spanish nurse infected with Ebola. Health officials decided to euthanize her dog as a safety precaution. More than 50 medical staff in that country are being observed for possible symptoms of the disease. They were in contact with the nurse. She was involved in treating 2 missionaries who have since died, who contracted the virus while treating people in Liberia.
You deserve to know more. ENCA.com
The ambassadors have got meetings somewhere. They want to leave as soon as possible.
Thank you very much. Are we set?
Okay. Yeah, because actually more about Walla, I wouldn't move worry. Could I look in John about the Walla? The ambulance check for ambulance.
10, and then the personal equipment is
16,000. The guy personally proceeded. I want to send volume.
And then give my visual to experts.
Honorable Minister, as far as we are concerned, we're going to take 1 or 2 questions and then we leave. Okay, we have another appointment. So maybe we should start with you if they've got any questions. Yeah, maybe. Yes. Joe. You know, the ambassadors are in a hurry. They've got other meetings, you know. They were prepared to take 1 question or so to leave. I don't know whether we just release them, we'll handle everything. We'll just introduce them and relieve them. Yeah, that's fine. Because if they start with questions before we... Yeah. Let me just Can I just introduce you and release you then? Yes. Yes.
Lois Brutus.
Sorry?
Lois Brutus.
Her name.
Lois Brutus.
Her name.
Liberia.
Oh,
Her name.
did I misspell it or what?
No. Just say the name is Ambassador Lois Brutus Liberia.
Oh,
Her name.
no, yes, I'm saying did I mispronounce it?
Somewhere, no?
Yes, I've written it. Oh, because I said Sierra Leone. It was a slip of the tongue, my sister. Sorry.
Thank you very much. We are starting the first conference, and thank you very much for coming as we invited you. I'm going to hand over to the Minister of Health in South Africa, Dr. Motsoaledi, to do the honor. Thank you very much.
Thank you very much, Joe. Ladies and gentlemen, good afternoon. Let me start acknowledging and welcoming the presence of my brother, the ambassador of Guinea to South Africa, Ambassador Mamadi Kamara, who is on my left, and my sister, the ambassador of Liberia to South Africa, Ambassador Louis Brutus, my sister on the extreme left. We were having a meeting this morning with them, the team that has been sent to West Africa, specifically to Liberia, which have been running a mobile laboratory there. And we've met people from the corporate sector who you saw here, who are contributing various equipment, medicines, money, and things that are commodities that are needed to help. That meeting has just been finished. Unfortunately, the ambassadors have got very urgent appointments and have asked to be excused. They said they are prepared to answer one or two questions, but I think it will be difficult to start asking questions before we make a statement, but unfortunately, they can't stay. So I want to take this opportunity to release them because I think their job has been done. I'm sure if you want to interview them later, you may do so. Are you having a question for them before they leave? One or two, they are prepared.
Okay.
First, please.
Yeah, my name is Business Day. Can I ask the ambassadors what they consider to be priorities now from Africa? English is okay, or I can do French?
What is the question?
What is their priorities? What is the African's priorities? Is there any other one? Sophie?
Support.
Your comments from both countries. Are you making headway in terms of the assistance robot to combat this and the impact in both countries? Your Excellency, just summarize the impact and perhaps the impact and perhaps the help you're getting from the international community and maybe further announcements that you have for us.
Okay. Ambassador, it's okay.
Yeah.
As for support from the rest of the world is concerned, I can say that Guinea has received a great deal of support from the World Health Organization, the Doctors Without Frontiers, CDC of Atlanta, and many governments all over the world. South Africa has pledged today, and the Honorable Minister will elaborate on that later, a lot of material, equipment for hospital, and so on. So what we need, because people are still dying in Guinea, and in Liberia and Sierra Leone. What we need is a massive and fast support from all over the world. It would be massive and fast, because every time we don't go fast, people will die. That's the main issue. Thank you very much.
For my country, the Republic of Liberia, first I would like to thank all of those countries,
because I'll give you
development partners,
you can't make your
NGOs,
presentation
that have responded
just a slide
to the call of my president, the government and people of the Republic of Liberia to come to the aid of the dying
you had 2 slides
in the Republic. We have received a number of support.
Of what you have
we have a lot of
the one that
NGOs on the ground.
countries.
The WHO is there.
Have done just 2
Medicine Sans Frontières is there. And all the other local NGOs are there joining us in this fight against Ebola. With respect to the countries of the world, countries from the EU have been very, very active in Liberia. And most importantly, the government of the United States of America has responded to the call of my government. And as I speak to you, there's a number of Americans on the ground from the military, and they are constructing a lot of hospitals, quarantine centers to be able to help us in the fight against this deadly disease. Basically, other African countries have sent us donations in cash and in kind to help us to overcome this deadly disease. But not only to overcome the deadly disease, but also to make it a sustainable cure of the disease. So meanwhile, the government of the Republic of South Africa has also committed themselves to sending a number of medical supplies, medical doctors in the Republic. NGOs are now will be gearing up to come to the Republic of Liberia, but not only Liberia. When I speak for the minority countries comprising Sierra Leone, Guinea, and the Republic of Liberia. So the support thus far with respect to the first question was indeed a little bit slow, but it's now gaining momentum. Because now the world has recognized this virus as a pandemic and a threat to international global security. So this is about all of us together joining the Act Now campaign to take away this deadly virus. There was another question that came from Sophie. And your question had to do with
that's the one you've just
answered. So I think I have addressed both questions at the same time. And I want to thank the press. For me, I think the press in South Africa have been very active. And they have brought the issue of the Ebola virus to the consciousness of the people of the Republic of South Africa. To the point too that I have been on the ENCA television, I have been on SABC, I've done a lot of interviews and television interviews all around. I want to commend this robust press of the Republic, and I thank you on behalf of the government and people of the Republic of Liberia.
This is the last one here. This is the very last one.
Thank you. This is Erin Bates from ENCA, and my question is for both the ambassadors, please. I'd just like to have your comment on the timing of the meeting with the South African government on tackling Ebola, since we know that this has been an ongoing crisis for the continent and the community of nations on the continent for many months. Thank you.
I think that the timing is all right, because every time a country intervenes in our 3 countries, it is welcome. Because, as I said earlier, every single day people die in our countries. So when we get support now or tomorrow, it's okay.
Thank you very much. For the Republic of Liberia, I think our situation is in such a nature that at this point in time we're not even deliberating the timing of assistance that's coming out from countries across the world. All we are urging countries, governments in the countries across the world is to take note of the fact that the virus referred to as Ebola is indeed a pandemic of catastrophic proportions. So we want to thank those governments that have already given the response, and those governments that will indeed give the response, because for each government they have their various peculiarities. They have the concept, the bureaucracy, what they have to go through to be able to put forward a significant package. So with the Republic of South Africa, we know that having deliberated with the Minister of Health, I know the package is coming to the three countries, and that package will be highly significant. So we want to give them a very big thank you.
I would like to thank the press. They are doing a lot to contribute to the fight against Ebola in our countries. I listened a lot of time to 702. There are a lot of chat about Ebola, and it's very useful. So thank you to all of you.
Thank you.
Thank you all so much.
Thank you. We'll do a follow-up. We'll do a follow-up to tell you. All right. When are the things starting to make arrangement about sending the equipment? Okay. The protective clothing is not us. We buy it from the government. The ones who are
Minister, the last thing I just want to say is that when the package is ready to go, we have to be informed so we can inform our
The embassy has to be informed. You have my card.
Yes, I do. Thank you.
Thank you very much. Now I'm going to hand over to
the one that shows that Canada did so much. America. That one.
Thereafter, we then ask for back to the minister.
Thank you once more, ladies and gentlemen. The press conference today was called not just to announce what happened in the meeting that was held earlier on, but to provide more information, seeing that, as the two ambassadors have said, the press is playing a very prominent and important role. But also, we do realize that it can also spread unnecessary panic. So we thought it's important to keep you abreast of events, to keep on informing you. As you know, this outbreak started in December 2013 in Guinea, and then it spread to the other countries. I want to remind you that since March, when the first cases were reported, because a question is always asked about our state of readiness. We have started as early as March 2014 by forming multi-sectoral national outbreak team, which coordinates our response to the outbreak. It met monthly with the Ebola Virus Disease as a standing agenda. We also need to remind you that we did send guidelines and alerts with case definitions. They were all circulated to stakeholders, public hospitals, private hospitals, even individual GPs. The stakeholders included provinces, port health, civil aviation authorities, laboratories, both public and private. They were all given guidelines. We also strengthened port health, the ports of entry, especially OR Tambo International Airport and Lanseria, because we expect that if there's going to be entry in South Africa, the likelihood is that it will be through the two airports. But we are also strengthening our surveillance, Cape Town International Airport and Kinshasa. But our biggest concentration of forces and person power is OR Tambo and Lanseria. Port health services, public and private healthcare practitioners were also put on alert, and they were given a number through which they can conduct the NICD, the National Institute of Communicable Disease, on a 24-hour basis. Any doctor anywhere in the Republic of South Africa has been given that number. We hope they are having them, so that on a 24-hour basis, if they encounter any patient whom they may like to ask questions, they will be able to phone NICD and it will guide them. And it has done so many times. I'm sure you are aware that in South Africa, we also called the SADC meeting, which coincidentally was in this very same hall, which was on the 12th of August. We made a presentation to the SADC ministers and we agreed on various things. On the 17th of August, there was a question here. I don't know whether the lady in front of me is from, did you say you from, madam? ENCA. Yes, from ENCA. She asked about our timing. My sister, we started on the 17th of August to start deploying. The team on my right, they are still going to talk to you, are experts from South Africa who were dispatched to West Africa on the 17th of August with a mobile laboratory. They are going to make a presentation to you what work they've done there. They have spent 7 full months in that area.
7 weeks.
7 full weeks, sorry. Not yet months, yes. Yes, they are still going to send months, but they spent 7 full weeks in West Africa. So the fact that we are calling the meeting now is not that we are just studying now. We're just ramping up as the virus grows bigger and bigger. Because in the beginning, everybody around the world believed that our initial response is that we'll hold it back. The teams that are the multi-sectoral national outbreak response teams in South Africa have increased their frequency of meetings from monthly to bi-weekly since the 20th of August. A National Health Operations Center, NATHOC, were activated to function 7 days per week to consider requests to travel and from high-risk countries. You are aware that there's been mentioned that we have actually banned total travel. What we have done was that we have a NATHOC which was working for 7 days, where from especially business people who want to travel can report so that we must know who's coming in and out, so that we keep abreast of the situation. We did not want a situation where there is movement between West Africa and here. And that movement is there. We have allowed it. We haven't stopped anybody from going there. The only thing is that we demand that they come and report to us here. A total of 869 travel applications were received and processed at NATHOC, of which only 2 were denied as they were deemed to be non-essential. I just want to explain that because there is a belief that we have totally closed down business activities between South Africa and West Africa. Since we put up this NATHOC, from the 25th of August to the 5th of October. This is the last figure I've got from to the 5th. I'm sure today is the 9th. Is it the 9th? Yes. No. So our last figure is the past 4 days. From the 25th of August to the 5th of October, this 869 applications of people who wanted to travel there have been accepted, and we rejected only 2 because we didn't think it was really necessary for them to travel. So there's no question about us having closed travel ban, even for business, social contact, etc., etc. It's not like that. But the advantage is that these 869 people who were allowed to travel, applications who were passed, we know who are they, you know when they left, we know from which area. If they have to come here, we also know, we know how to trace them. That is the advantage of that travel control. And we really like you to look at it as travel control rather than a travel ban, because really from what has happened, you can see that nobody has been banned. The Director General has held meetings with these companies that are doing business in West Africa, but also corporate sector in South Africa, especially at the Johannesburg Stock Exchange. That meeting took place on the 12th of September and the 19th of September, where CEOs of companies in the Johannesburg Stock Exchange met. And as you have seen, they have just been here today. Through these meetings to date, 18 companies pledged services, goods and cash in the humanitarian crisis to West Africa. Up to so far, the goods and services are to the value of 12 million rand. All 9 provincial outbreak response teams and 51 health districts, with an average of 25 health officials in each, have been trained, and we believe they are ready. They've been trained in epidemic preparedness and response. As part of the monitoring preparedness activities in provinces, bi-weekly teleconferencing was initiated since the 15th of September. So we are in touch with the provinces by teleconference since the 15th of September on a bi-weekly basis. With regard to training also, as I've mentioned, from 7 August to 17 September, approximately 525 health and laboratory workers at 13 hospitals, including the 11 designated hospitals, have been trained and they are ready. On the 22nd and 23rd of September, 80 officials from all the 15 SADC member countries were trained at the National Institute of Communicable Disease in South Africa. From 19 September 2014 to the present date, around 270 officials at 9 identified high-risk ports of entry were trained. This training will still continue. The fact that I said we have put our concentration on OR, Tambo and Lanseria doesn't mean the other ports of entry, there's no training. We have trained 270 officials from 9 ports of entry since that period. All laboratories testing for EVD are handled at the NICD. Since the 24th of March 2014, they have tested 14 patients in South Africa, 2 from Namibia, 1 from Zimbabwe. All these cases were negative. And I want to emphasize that the cases that were tested at NICD did not meet case definitions of EVD. I want to emphasize what I mean. The people in NICD are clinicians, not just technicians. They are not just there to feed blood into machines. They are very highly trained technicians who must assess who needs a test and for what reason. The 14 people who have tested up to so far in South Africa, To tell you the truth, we were testing them just to settle your nerves. Honestly, clinically speaking, even me, I'm not an expert, but I happen to be a trained doctor. Clinically speaking, most of them did not meet any criteria of being tested. Well, except if you say somebody has been to West Africa, but that's not the criteria for testing. As Professor Janus will tell you, they are not testing everybody there in Sierra Leone. They are not testing every human being just by virtue of them being in Sierra Leone. So why should we test everybody here just by virtue of coming from there? We were testing, I emphasize, to settle your nerves. And I hope we did settle them, even though we're still seeing a lot of frayed nerves, you know. So these tests were really done in order to address fears. The most diagnosis of this test was bacterial sepsis and malaria, which we've been living with for a long time. So many people in the media no longer believe that anybody has got any business in developing high temperature. It's a general belief now from you, from the way you inquire from us. But people develop a lot of high temperature, and for us, even these 14 cases will never test for Ebola until we get our results for malaria. That's the first one we test for. And only when malaria is negative, we then move over to Ebola. Even with all these 14 cases, we did so, because that's the commonest. It is not acceptable, ladies and gentlemen, to have a media frenzy every time we get somebody with fever and bleeding. It looks like we are now banning fever and bleeding in South Africa, which have always been occurring. I'm not being rude, I'm telling you, because every patient who bleeds, we don't sleep that night. We get lots and lots of phone calls for every person who bleeds, and yet bleeding is part and parcel of what the medical personnel see. We promise, because the people who phone you every time they see a bleed. I was made to run around one day with somebody with epistaxis, a nosebleed. And I'm sure you all know how common a nosebleed is. You know, since you were born, I'm sure you have experienced it many times. But we were made to run around. So I just want to inform you that the symptoms for flu, fever and hemorrhage, flu-like symptoms, fever and hemorrhage, are the symptoms of viral hemorrhagic fevers, not only for Ebola. Let me take this opportunity to welcome Mama. Welcome, Mama. Thank you. She is representing one of the donors that is preparing. Mama Winnie Madikizela Mandela is representing some of the donors. She's working with them to try and organize a mobile crematorium, because as you will hear from Professor Janus, 50% of the infections there are caused by funeral rituals. And so we believe there must be a crematorium, and that crematorium is still being constructed to be sent to West Africa, and Mama Winnie Madikizela Mandela is working with the team that is doing that. Welcome once more. The latest media frenzy, I think it happens about 2 weeks ago, 2 days ago, where we did not sleep, around the 72-year-old man who presented with fever and bleeding is a case in example. This old man has never traveled anywhere outside the country. He was in Northwest in a hospital in Potchefstroom. And throughout that night, we could not sleep. I want to explain why we isolated him, because we'll keep on isolating people. There are 3 types of viral hemorrhagic fevers. If you may allow me to give. just a bit of overview for you to understand. The first group are propagated by rodents. It's Lassa fever and Lujo fever. The second group are propagated by arthropods. Arthropods meaning insect-like organisms. The most commonest is Congo fever, which is propagated by ticks. Now, Congo fever is endemic in South Africa, in the Eastern Cape, in the Free State, in the Karoo parts of Western Cape, in Northwest. That means in the dry parts of this country, Congo fever is endemic, is very common. So quite time and again we do isolate people from Congo fever. And so when we don't inform you, it's not because we're hiding, because we've been doing that for ages. I'll come back to this story of Congo fever again. But I just wanted to inform you that those viral hemorrhagic fevers that are propagated by arthropods is Congo fever, which is endemic in the areas I've mentioned, is dengue fever, which is propagated by mosquitoes, is yellow fever, which we know. Many of you have traveled. At the airport, they require a yellow fever certificate for you if you are traveling to a country which is endemic for yellow fever. So we've been doing that for ages also. Then there is also Rift Valley fever, which was named after a valley in Kenya. The last group are propagated by birds. Unfortunately, this is the most deadly group. It's Marburg fever and Marburg virus and Ebola virus, which unfortunately is the subject of what we are dealing with. So time and again, patients will come with some of these issues I've mentioned. They'll come with Congo fever, as it commonly happens in South Africa. They'll come with yellow fever, they'll come with dengue fever, they'll come with Rift Valley fever. We will isolate them. And we might not even inform you, because this has been happening for a long time. So when a health worker who doesn't understand phones you, don't think you caught us before because somehow we were hiding. South Africa gets 5 to 10 cases of yellow fever every year. At most, we get 20. And that has been happening for the past 50 years in South Africa. Yes, the fact that we did not tell you about it is because we only report to the World Health Organization when we get more than 20 cases. Once the case of Congo fever are more than 20, then it's called an epidemic. We report publicly to the World Health Organization. If there are less, we don't report to you. Like now, we've already had about 3 cases, one of which passed away. We never reported because it's something that has been happening for the past 50 years. So when this old man arrived in Potchefstroom with fever and bleeding because she's from Northwest, she was isolated, and the first test we did was for Congo fever, not for Ebola, because there was no reason, there was no indication whatsoever. But we were forced to do it by you. Anyway, even after the Congo fever was negative, that man is negative for Ebola. It is also negative for Congo fever. We are treating him for bacterial sepsis. I don't know why you usually get disappointed when I give news about a negative story. I think you should cheer. Yes, I've seen you many times. I don't know whether it's my impression, but I got an impression that every time you have been waiting for results of a test, when I tell you that's negative, instead of cheering, you get disappointed. Why do you want such a very, a killer disease in your country? You should be cheering yourself that we still have many more weeks without this disease. So I'm emphasizing we are still having no Ebola virus in South Africa, including this old man. He has got bacterial sepsis, and we are treating, is being treated for that. Ladies and gentlemen, just to ratchet our preparedness, I have decided to appoint a ministerial advisory committee on Ebola that consists of eminent persons from the public health sector in occupational health, infectious diseases, virology, emergency care, logistics, laboratory medicine, and management. I wish to introduce to you, I don't know whether they are here, I don't think so. Some of them. Yes, some of those who are here. Professor Martin Vela from Wits University, he's the dean. He's implementing the whole support. He's organizing all these organizations who are here, whatever they donate, whether it's medicine or clothing or all that, Professor Martin Vela will coordinate that. He's the dean of the Faculty of Medicine at Wits University.
Thank you.
Thank you, Professor. I also want to introduce Professor Guy Richards, an infectious disease specialist at Wits at Charlotte Maxeke. Most of the running around at Charlotte Maxeke has been done with him, so he has been in the trenches for a long time. I also introduced Professor Lillian Dudley, University of Stellenbosch, a public health specialist. Professor Mark Mendelson, University of Cape Town, infectious disease specialist. Professor Lee Wallis, University of Cape Town, emergency response. He's the one who was sent to Nigeria, who directed that team and brought the injured people here, Professor Lee Wallis. Because of his experience in emergency medicine, we believe if there is any trouble, he will be one of the first people who will coordinate the activities of what we do in an emergency. That's why we sent him to Nigeria, and he was able to bring back the people who survived that disaster but had to be treated at the Steve Biko Academic Hospital. I also want to introduce Professor Koleka Mlisana, University of KwaZulu-Natal. She's a medical microbiologist, a specialist in infection control. Also, Dr. Tanda, it's difficult. Yes, Dr. Tanda Kew, University of Limpopo, is a virologist. Dr. Ruth Ligalakala, University of Pretoria, medical microbiologist. Professor Lucille Bloomberg, you know her very well, from the NICD. She's a specialist in laboratory and travel medicine. You have spoken to her many, many times. And Professor Janus Paweska, on my right here, he's still going to talk to you. Also from the NICD, he was heading this team that spent 7 weeks in Sierra Leone. He's also going to be part of this advisory committee. We also have Colonel Theo Lythelm from South African Medical Health Services. He's a specialist in logistics and emergency response. And lastly, I've got Dr. Berikis Nasabi. He was around here somewhere, who is representing the Department of Health. He's an occupational health specialist from the public health sector. This is the team that we'll refer to time and again when we have got problems. And their terms of reference is that they'll provide technical advice to the Minister and Director General of Health on the Ebola response within South Africa and also SADC. They'll provide advice and support for the Department of Health interventions in Guinea, Liberia, and Sierra Leone, particularly Professor Paweska here, who knows everything about what's happening there, not from reading in a newspaper or in a book, by being on the ground. So when I want advice, it'll be very handy. They will also help to keep abreast of the unfolding health and humanitarian crisis that's unfolding in the affected countries. They'll provide technical reports on any aspect of the health and the humanitarian response. They'll provide oversight and support for the implementation of the response activities through the University of the Witwatersrand Vet Health Consortium. That means through Professor Martin Vela, this team will provide oversight and support for the implementation. They will keep on informing me whether we're doing well or whether we're lagging behind or whether we need to strengthen somewhere, because they'll be sitting and watching. Now, ladies and gentlemen, as I've said, the companies that have contributed the ambulances you see outside. They've contributed the scooters you see here. yes, there are 10 scooters already. We need 75. So we are still 65 to go, because these are the scooters that are going to be on the field there in West Africa. Of course, we still need more ambulances. We, as a government, have purchased 16,000 personal protective clothing, which is to be delivered there by the World Health Organization, because they are the agency we used to acquire those protective clothing. We have got samples there. They have got medicines, disinfectants, everything that is going to be sent. We are eagerly waiting for the mobile crematorium, which Mama and them, I think, is the Tokyo Swale and the Nelson Mandela Foundation, which are organizing that. We're eagerly waiting for that. We think the sooner they get the crematorium there, it will reduce the amount of infections. I will take this opportunity to give a minute to Professor Paweska to introduce his team. You are going to ask questions later.
I just need one question, Honorable Minister.
No.
I just need one answer.
Are you living?
I'm an HIV positive person, the longest survivor on the planet. I would like to know, people with compromised immune systems like HIV positive people, is there anything in place for them, and are we planning anything for HIV positive people? I've been living with HIV for 34 years. I am very perturbed. There's not a sound.
Can we hang that question? You'll ask it during question time. You'll certainly get an answer. We've got enough experts here. So don't worry. But for now, allow Professor Paweska to introduce the team. He's just going to show you about 4 slides of their experience in West Africa. From there, we'll ask questions. We'll start with your question. When he has finished. I want him to introduce the people first, so that you must see them, because everybody believes the presence of somebody from West Africa smells dooms. As you can see, I'm sitting very close to them, and I'm not even scared. Professor.
Thank you very much. Let me introduce the team. This is the first NICD MLU mobile laboratory team, which was deployed in Sierra Leone on the 17th of August. From my right, Mr. Gintermeyer, and he was responsible for the biocontainment and logistic operation of the mobile app. Dr. Janssen van Vieren, he was responsible for the hot processing, which we did together in the biocontainment facility set up in Freetown, and also for PCR molecular testing. And Chantal Leroux, molecular biologist and virologist, she was responsible for running the PCR extraction and also supporting many other activities in the lab. Basically, when we arrived there, we were everybody, starting from being a cleaner, because we had to clean the lab, to being a highly technically skilled person and to reporting these results to the doctor. Are you able to show? I am unable now because
no. Now guys, you have blocked this computer. Can you just remove a few?
Just one maybe slide to give you some kind of information about the diagnostic capacity in Sierra Leone and what are the plans. We just have to open a little bit. Unless I would just take this one. Thank you very much for your time. Just to explain you, the Ebola diagnostics, it's not something you can actually buy from the shelf. You can't really compare the diagnostics or capacity for diagnosing Ebola, like diagnosing malaria or HIV/AIDS or measles or rubella. It's an unusual capacity, highly scattered around the world. And before this outbreak, this capacity was only available in a single countries around the world. You might know that here in South Africa we've got the only biosafety level 4 capacity, which we also call the maximum level security lab for working with highly dangerous viruses, including Ebola Outbreak and some of these viral hemorrhagic fevers already mentioned by the minister. So with time, we also developed a capacity for mobile deployment. I give one example because sometimes people don't understand what is a mobile lab. Usually people think that there's a suitcase and you just take the suitcase, you jump on the plane, and next day you're doing the Ebola diagnostics.
Put the mic a little bit far, it's having an echo.
Somewhere in Sierra Leone or Liberia or Guinea under the tree. It's not like that. To deploy a proper mobile lab, you have to consider a number of protection barriers, equipment, suppliers. So the mobile lab which was shipped to Sierra Leone was about 2 tons. So you can imagine that this is quite a lot. I don't have the time to go through the whole presentation, but if you just look at the slide here, there's a number of mobile labs which are operational or being planned to be operational in Sierra Leone. You might know that the Ebola outbreak is not yet under the control. And every 20 days, the number of cases is doubling. So there's a huge demand for the diagnostic capacity. Why you need this diagnostic capacity? You need it because you have to distinguish between people who are infected with this virus and who are not infected. Those who are infected, they are directed to the isolation ward. Those which are not infected, they can leave the hospitals, and these hospitals can be used for other services. Also, the diagnosis of Ebola helps the doctors with patient management, including treatment, and so on and so forth. So the diagnostic capacity of providing the diagnostic services is extremely important in controlling the outbreak, but also in the patient management. So with the support of the Ministry of Health and the Maternal Institute and ICD, National Institute for Communicable Diseases, and some other international organizations, including WHO, we were deployed in Sierra Leone, and we worked there for 7 weeks. And we tested more than 1,400 specimens. About 55% of these samples were highly positive, and we handled this virus. We handled 1,400 blood tubes highly loaded with Ebola virus. And every second blood we tested was positive, and we see the life. Why? Because we trained and we know how to do it. And we do have this expertise in the country. So there's a number of mobile facilities in Sierra Leone. It's a Canadian lab, it's also a CDC lab, and it's also South African as well, as described. China CDC just arrived 2 weeks ago. There's a Canadian lab and also Public Health England and international medical corps. But you can see that some of these labs are not active yet. Okay, that's the plans. They will be operational very, very soon, but not yet. Our diagnostic capacity, daily diagnostic capacity, is to do 58 PCR reactions. But there is a great need and expectation that the South African mobile lab will actually upgrade the diagnostic capacity, at least doubling the current capacity. So there's some discussions, because that is quite costly. For example, the budget has been made, and to upscale our diagnostic capacity in Sierra Leone and Freetown, the placing of this lab is actually ideal, if I might say, because the number of cases in Freetown is increasing, and also in surrounding areas is also increasing. Actually, historically, the outbreak moved from east to west of Sierra Leone. So there was a very, very perfect timing for us to actually strike in this part of Sierra Leone. So for another 6 weeks operation of this lab, we would require about 6 million rand. It's very costly. One daily run for 58 PCR reactions is about 10,000 rand, just the PCR reactions. So it's very, very expensive diagnostic service. So by saying that, I don't know if I should still show some slides or that's...
Yes, sure. But we said 4 slides.
Okay. It got stuck here. Right. Just maybe go to this slide. So, okay. One does want to recall. Okay, so this is just another table which has been recently developed by the Sierra Leone National Ebola Response Plan, and amongst other things, I just pull out the items which are concerned with increasing the laboratory diagnostic infrastructure. So you can see that there's a number of deadlines, and some of these labs from England, for example, and from other countries will be only operational by the end of this month or even on the next month. But because the outbreak is on increase, I think this kind of a planning is very related to the questions you had, when South Africa started. We try to address the issues accordingly to the developing situation. And because the needs and the situation is worsening, obviously the response is becoming more and more, you can call it comprehensive or on a higher level or massive, or because obviously there's a lot which is needed on the ground.
Show that one
with
show, yeah.
Okay, I would like to actually show you just that. Okay, this is, we've got a technical problem here. Okay, this is one of the biocontainment facilities which are used in Sierra Leone in a lab which we set up. We call it a glove box. Basically, it's like a plastic tent. Okay, has got a very, very light structure, plastical structure, and we're using this as a barrier which protects us against direct contact with clinical specimens. So it's like a box which has got ports through which we can put your hands into the gloves and then work with the specimens within this area. This is not a picture I wanted to show you. Dr. Petrus can you just move this? Because for some reason that doesn't want to play. So now it's playing, okay. A magic touch. So what you can see here, we are isolated from the specimens, from the blood tubes, through this plastic shell, and can enter the space inside the glove box through these gloves and ports. And this is just opening the container, which contains centrifuge blood tubes, blood which was collected from suspected Ebola patient, and that has to be done very, very carefully. And you will see that we can't really talk to each other, but we have to understand each other. So if I move my hand, Petrus has to understand, what I expect from him. Passing, trying to help each other, moving specimens around, and the whole processing procedure obviously has to be harmonized and executed in a way that there is no spillover and there is no break in the tubes and so on and so forth. So that procedure requires highly trained people. Very often, we spend very, very long hours processing those blood specimens, and we not only protected by working in the glove box, but our hands are protected by 3 layers of surgical gloves, and the black gloves you're seeing is a heavy-duty glove. So we have like 4 layers of plastic in our hands, just to be 100% sure that the virus or the blood which we touch doesn't actually contaminate our skin. Plus, there's a number of our protective measures which we take. I think that's...
Just show the last slide, the one with proudly South African.
Oh yeah, okay. So let me just show you another slide here.
Then we stop.
And then we can stop. I just follow the kind request of the... Okay, let me check. That one. Just need to recall. It's the last one. This is the South African team, and as introduced already, Dr. Petrus Janssen-Van Chantal Leroux, and Mr. Ginter Meyer, myself. That's the first team, and the second team arrived in Sierra Leone 2 weeks ago. It's almost 3 weeks now. So that's Pumza, this is Nadia, and this is Alan Camp. We're supported by the driver. I think what we'll be able to see is another picture. I just don't want to get another picture which, sorry. I think we have to ensure. That will be just that one. All right, just move it. Just want to show you one picture here. That one, I think. So this is the picture just showing the different areas of the lab, but also is that the picture you're looking for? Probably South African. All right, so this is our office in Sierra Leone, and we display the flag there. When we visited by the president of Sierra Leone, she promised actually that he will give also Sierra Leone flag, so we can put next to the South African one.
Leave them to ask questions.
All right.
Okay. Maida, can you come and conduct questions?
Any question, guys? 1, 2, 3. Any other?
Yebo.
Minister, I just wanted to find out, earlier on you spoke to us about how 14 tests were done, which one was Zimbabwe. Now I wanted to find out...
14 were done and what?
14 tests for Ebola.
14. Yes, 14. Yes.
And you said of which one of them was from Zimbabwe. So I wanted to just get clarity that this particular case in any way related to the patient at the Wilkins Hospital in Harare. And if so, is it true that samples are indeed being sent to South Africa? And I also wanted to find out that if that is the case, when can we expect results about that? What would it mean for South Africa? Particularly looking at the travel movement between South Africa and Zimbabwe. Last question, I just wanted to understand that today we've heard a lot about all the support that's going to West Africa with regards to the Ebola outbreak. How sustainable is this support? For how long will we see this support continuing to go towards fighting Ebola in West Africa? Thank you.
It's 14 cases from South Africa, 2 from Namibia.
Yeah, I will let Professor Madi, the director of NICD, to respond to that question about Zimbabwean patient. Prof, can't you come this side? Oh yeah, okay.
Yeah, Prof will answer, but let's take a set.
Okay, my name is Bokiwe Kumano from ENCA. My question tallies to the case from Zimbabwe. Are we, is South Africa ready to practically, prepare itself for a possible influx of expansion
Are we? Your mic is dying.
Okay, so basically the question, okay, I'll just write it down. It just tallies on that. Are we ready as a country?
You don't have a good voice, please try the mic.
Okay. Are we ready as a country to be able to, prepare ourselves for a possible influx of such tests that may come from, like requests that may come from our neighboring countries? But the other question would be to the team. We've just heard of the highly specialized tests that would have to be done and the highly skilled personnel that was there. But can they also paint a picture of how the situation was on the ground?
Thank you, Minister. My name is Inga from Longwood News. I want to congratulate our country for their efforts to try and help those cases that are suspected of Ebola. First of all, Liberian markets were had to close because of some of the markets were selling fruit bats and some monkeys, and they suspected that Ebola is coming from those animals. So is it only about through traveling that Ebola will land in South Africa, or what is the chance of Ebola coming to South Africa through forest animals?
Through what?
Forest animals. Forest animals.
Oh.
Let's go next. Yeah, so. Yes, sir. Yes.
This is addressed to the Minister. Rob Saliers from Associated Press. I'll just speak up.
Okay.
You mentioned earlier on about South African preventative measures against this virus, in particular Ebola Virus. Could you perhaps elaborate on what preventatives these are, in fact? Anybody coming into the country? And do you intend to expand your preventative measures, whatever they might be, to other border areas of South Africa?
Thank you. We'll answer this side and then we'll get to the next side. Thank you very much.
Yeah, so I'll take the first question in terms of the cases that have been tested in South Africa and the reasons purported referral from Zimbabwe. So as the Minister has already correctly outlined, the NICD is in the business of doing testing for Ebola and other hemorrhagic fevers. It's part of our routine. It's not something exceptional. The 14 cases that were tested were really tested to appease the physician's state of mind rather than the 14 cases actually fulfilling any sort of clinical criteria which made them highly suspicious of Ebola virus. And all 14 were subsequently tested to be negative. At this stage, the one test that we had performed from Zimbabwe is not related to the current patient in Zimbabwe for which a test was requested. The test that we completed was reported to be negative. On reviewing the current data of the current case that was referred to us, it was a citizen of Congo that was referred to Zimbabwe. It was a student, in fact, and upon review of that particular person's clinical status, we've decided not to test because, in fact, it isn't suspicious for Ebola.
Prof, can you also answer the question about if there are influx of tests from SADC, whether we are ready? But before Prof answers, NICD is a World Health Organization collaborative center. That means every 4 years, the World Health Organization chooses certain laboratories, whether for training, for testing around the world, and they name them collaborative center, which means there are very high referral centers which are recognized at that level. And NICD is one of those. Because there's no other collaborative center in SADC, so we'll have to do that work. We've got no choice. That's why I've just received a letter of confirmation, I think in August, for another 4 years of NICD being a collaborative center. I've also informed you, I need to remind you, that the BSL-4 laboratory, the Biosafety Laboratory Level 4, in the whole continent of Africa, is found here only in South Africa, at the NICD. So what we are doing is national and international duty, for which we have been given accreditation by the World Health Organization. So we have got no choice. When we met with the Minister of Health here from SADC, They declared that the only laboratory that they will rely on for the whole of SADC is NICD in South Africa. So we are combat ready for that. I'm sure, Prof, you'll mention whether if there is an influx of tests, whether we can manage, and also the chance of Ebola coming through forest animals.
So,
I'm sure it belongs to you. And yes.
In terms of responding to whether South Africa has got a capacity to upscale our testing for Ebola, firstly, I think it's important to recognize that the chances of a similar sort of an outbreak at a scale that's been observed in West Africa or occurring in any of the southern African countries is extremely limited. So I think that's the first point to note. In terms of what capacity we've got, as the Minister has pointed out, the NSC has got a BSL-4 facility which wasn't built yesterday but which has been functional for over 3 to 4 years. We spend a fortune each year just to make sure that the BSL-4 facility is kept up at an international level. We obviously have got Prof. Baveska and his staff that's staffing. So we've got a capacity to exceed way beyond what we're able to do in Ebola lab in Sierra Leone in terms of testing capacity in South Africa itself. So I've got very little doubt that should there be a need for an upscaling of testing in South Africa, on behalf of the SADC countries, the NICD would be in a position to deal with it.
Forest animals.
That's a tough one, for me. The source of the Ebola is still enigmatic. Obviously, there's a prevailing hypothesis that bats are the source for infection for humans. Likewise, other wild animals, including gorillas, chimpanzees, but also monkeys. And yes, this is how it happens. That the contact with these animals lead to the primary transmission, and this transmission from the in this case is spread to the family members, and eventually this family members goes to the hospitals, and it's spread between healthcare workers and so on and so forth. But the chance of spillover of viral virus like Ebola or Marburg in this part of the world is highly unlikely for a number of reasons. Our recent study don't show any evidence yet, or clear evidence for prevalence of this of Ebola in this population. Secondly, there is no habit of eating bats in South Africa. Maybe this habit might change, but I don't think that this is likely. Also, the hunting procedures are also much different. So the need for hunting bats and for hunting wildlife is due to the fact that people are just hungry in Central Africa. You know, they're hungry for protein, and they will do that. I think we're much better off, and I don't think there's such a drastic need for people to do that. So what I'm saying is that the change in human kind of behavior is actually contributing to the spillover of some of these dangerous viruses to the young populations. I think we're safe for now.
There's a question of how long are we going to maintain this support. I think the world must maintain the support for as long as is needed, because this has already been declared a public health emergency of international concern. And 2 weeks ago, I was at UN, where United Nations Secretary General decided that they will coordinate at the UN level and called all the countries to do their level best. So we can't, if we stop and say we have done enough, the virus will spread and it will go to every corner of the world. So it's better that we all go there to help to contain it in that corner, and we must do so for as long as possible until there's no longer a chance of any spread. The other question I want to respond to, as they were talking about this issue of wild animals, there are certain practices or certain traditions in West Africa that do not occur here or are not prevalent here. One of them is the eating of birds. I don't know any tribe or any nation or any race or any village in South Africa where they eat birds. It's just not, they eat mashonja, of course, the Mopani worms in Limpopo, but the Mopani worms do not carry this. Other people eat frogs. There's a frog called Litlametwa in Limpopo which is eaten. It doesn't carry this. It just so happens that the people in West Africa were unlucky to be eating a bird, and that is the carrier for this virus. And nobody in South Africa has ever eaten it. The other is our burial rites. In DRC, where the first Ebola virus was ever diagnosed 38 years ago, because it's for 38 years, they've changed the behavior of people. I'm sure you are aware that there's an outbreak in DRC, which is unrelated to this. Everybody's forgetting about it. They've been able to contain it immediately because they've been having it for 38 years. They know what to do. The minister was briefing us in SADC that immediately there is an Ebola outbreak in the DRC. They go to that village. The government goes to that village. They call all the chiefs and donors and leaders in the village. They tell them that there is Ebola. From now onwards, every funeral is conducted by government. Then the villagers don't argue. They tell them, you're no longer going to bury your dead. The government will do so. Because they want to do it in such a way that the dead body doesn't transmit the virus. Now in West Africa, because it's for the first time that the virus has ever occurred, they still have a tradition of coming into contact with with dead bodies and touching them and all that. And they have to have that behavior, but I mean a change of that behavior, but it's going to take a long time. Even in the DRC, it took a long time. Now they know, because 38 years throughout that period they've been learning. And so when the government comes and say we've got Ebola, we are taking over all the burial ceremonies, people don't emotionally fight or feel deprived because they know what it means, and that's why they'll be able to control it. The borders, all I said is that we are putting a lot of emphasis on OR International and Lanseria. I never said the others were ignoring. I said all our emphasis, most of our emphasis, let me say, is here because we think if there is any chance of getting Ebola in South Africa, it's going to come via an aeroplane, not via a white animal. It's going to come via an aeroplane, which will land in OR Tambo or Lanseria. Not that it won't happen in the other airports. We are looking at probabilities here. But the other 9 ports of entry, we have trained health workers there. We are ready. It's only that, for instance, there's been question about people jumping fences and how do we know that they've got Ebola. We are talking here of possibilities and probability. What is the possibility of probability of anybody moving from Sierra Leone or Liberia or Guinea on foot, coming to South Africa, having no passport, jumping the border there, and being ill from Ebola, which has got that period of about 21 days.
Up to 10 days, usually 10 days.
Yes, up to 10 days or so. And that person just comes and cross the border, jump the fence and come into South Africa. The chances are very slim. I'm not saying it won't occur, but my mathematics tell me that the probability is very, very, very low for that ever happening. And that's how we are trying to combat this disease. We are looking at probabilities because you don't also want to throw resources in an area where it's quite unlikely for anything to happen. So the airports that we are looking after are the ones where we think something is likely to happen there. And I'm sure you are aware that all over the world, the countries in Europe and America, this virus came through the aeroplane. I'm sure you are aware of that.
So could you just elaborate on how you're going to screen that potential virus coming in, say, at our airport? Is it a temperature control device, or how do you detect a possible threat coming in through the airport?
Well, let Dr. Free Benson answer, but the first thing is that the people in West Africa, the World Health Organization has also put people there for an exit screening. People don't just get into planes and go. They get screened, they get asked questions, and there are those who, if it's necessary, they are advised not to travel, or they are told not to travel because there is doubt about them. So the people who come have already been screened. When they arrive here, there is a question. Anyway, let me allow Dr. Benson to try and help.
Yeah, the first area of protection is the exit screening that happened from those countries. Any person that has been in contact with a person suffering from Ebola virus disease are not allowed to travel. If you are in contact, or any person with symptoms are not allowed to travel. So that is already a barrier for us. Now, what we do as a country, and when the travel advisory was introduced, obviously we have temperature screening. We would want to roll it out to a number of other airports, particularly in Cape Town and in Durban, because those are our busy international airports. But in addition to that, the people that come from West Africa, we introduce questionnaires. Now, the reason why people need to apply to us to come is for us to let them complete the health questionnaires that look at the symptoms, the common symptoms, fever, headache, vomiting, diarrhea, so that we can pick it up. What we also do, when a person registers at what the minister informed you about, our operation center, our National Health Operation Center, the person gives us their contact details. And for 21 days, our network also follow the people up telephonically. That there are a couple of people that give wrong addresses. For instance, a person may say, I'm going to this hotel, and give that hotel address. But that's a low percentage of people. What we do with those people, in our provinces, we have outbreak response team. And they are looking to follow up and trace those particular people. But we monitor the people for the incubation period. It can be as long as 21 days to see if they develop any symptoms.
Thank you. Just to add to that, not only at the airports is a screening for temperature or temperature screening. It is in the interest of those affected countries to control this outbreak as soon as possible because of many reasons. I mean, kids are not going to the school for more than half a year. Okay, the business is going down and so forth. So, for example, when we were moving from Freetown to the airport, we were checked twice on the road for the temperature. You remember that? Okay, so there is also some temperature check within the country when people are moving from one province to one district. And especially, there is definitely at least twice temperature check on any road to Lungi Airport, at the airport as well.
The last round. 1, 2, 3, 4, 5, 6. In that one. Okay.
Minister Barrett, just a question on the 18 companies. Can you name the companies perhaps, some detail on who they are? And then the ambulances and the scooters. When will they be moving? Where exactly will they be going? And then it's quite obvious what the ambulances will do. Can you explain exactly what the job of the scooters will be? Thanks.
Yes.
So I've got up on that. Just in terms of this briefing, you've announced the establishment of the committee and some of the donations that have been made. Is that really the kind of crux of what this is about, besides all the information on South African testing and the fact that there are no cases? The news is the committee, the donations that have been made, and the amount from the 18 companies. That's kind of the gist of the
You want to know what
the results of the meeting, the fact of the committee, the donations, and the corporates. You can just go through that, please.
Yeah.
My question is just with regards to the mobile crematorium. How exactly will you deal with resistance in my case where people feel like you abandon their traditional burial practices? Because I know as Africans that's something that's very important to us. So how are you going to
Yes. Don't really have a mic. Try. Right?
Okay.
Minister Azmile Gordon from ANC. Ebola has some of which catastrophic levels. Do we in South Africa have some of those drugs that have proved successful or cleared symptoms for Ebola in case we have a patient?
Just come again. Drugs to do what?
Do we have the drugs that have been successful or cleared this in other provinces or in other countries in South Africa in case we have a patient?
Drugs.
Treatment.
Good. Any other? Okay, can I borrow my mic?
He's talking about medication to treat. You want me to name the companies? That's a long list. They will give it to you. There is a list here. They will give it to you. Joe Maila will give it to you.
The list
Follow me.
They don't seem to be happy that I'm not giving the list. Yes. Okay. Mvela Panda, IPASA, Netcare, Standard Bank, Aspen, Vet Health Consortium with Right to Care, Reproductive Health and HIV Institute, Discovery, Pfizer, First Trend Bank, Pioneer Foods, Novonostics, Omnimed, Vuma Reputational Media, Tageda, MedScheme, Bayer, Clinton Health Access, Profile Media, National Business Initiative, Redis Laboratories, Government Employees Fund, MassMart, Life Health, Sanofi. And Acacia. And others are still being awaited for. Actually, he is supposed to be, it's not Mvela Panda, it's the Tokyo Sowale Foundation with Nelson Mandela Foundation. It's not under Mvela Panda. Yes. The scooters, what's their use? They have to trace people. They must move around. There will be health workers and lots of teams there which need mobility to try and trace people. And they'll use the scooters also because of the terrain over that side. The outcome of the committee, of the meeting that took place here, yes, that meeting was for pledging. These are the companies that have pledged and who have donated some of the things we have seen around here. We wanted them to hear firsthand from the ambassadors who were here, to hear exactly what more is needed. That's why we needed the meeting. The resistance to the crematorium. Unfortunately, you were not here earlier on. We don't think there will be resistance. We remember that a lot of human behavior has to change in this. It is true that a culture that we've been practicing for ages is not easy to change, but we were not here in the meeting. When the ambassador of Liberia was outlining a situation that will just make your tears flow, he said a 2-month-old baby was found sucking on a mother who has passed on, because nobody was ready to collect that corpse. Everybody was running away. Immediately they realized this lady has passed on. They all disappeared, leaving a 2-month-old baby there to suckle on this mother who is already passed on. That's what the ambassador said here earlier on. Now with that situation, you don't expect people to resist. They need help, because as they said, some of the corpses are lying all over the streets, because the moment you fall down, people run away and disappear. Now it will infect many more others. In the beginning, they've asked for a mobile mortuary, but we believe once there's a mobile mortuary, there'll still be contact. So it's better that the bodies be cremated as they are found. And we think once they see the need for that, because it will help cut down the infection, So we really don't think there will be resistance. The issue of drugs, remember, Ebola has got no treatment up to so far. There's no known treatment for Ebola. People have made a lot about that American ZMapp serum and all that. Remember, it was given to 3 people. One of them passed out on. The other 2 lived. No scientist has got any proof in the world that it was because of it. It's still in experimental stage. So for all intents and purposes for now, Ebola has got no treatment. What we are treating are symptoms. Like when President Clinton called us, oh gosh. When President Obama called us 2 weeks ago to talk about global health security, they invited a doctor from Liberia, who is a survivor. He was sick, very sick, from Ebola, and he was with us in Washington, explaining exactly how he survived. He said he was virtually forcing food down his throat because he knew he had to survive. He said you virtually don't want any food, and many people die simply because they are eating nothing. He said he had to force it down, force himself to drink, giving people fluids, giving them food, giving them blood when they bleed a lot, giving them antipyrexia when the temperature goes very high. That's all we can do is supportive treatment, symptomatic. But to treat the virus itself, we don't have any medication yet anywhere in the world.
Thank you very much. We've come to the end.
That's lunch.
Okay. Sorry. Oh, when and where are they going?
Can I just explain?
Yeah.
As on Monday, the Base Health Consortium were having a meeting to look at all the supplies that have been pledged and to work with the logistics companies to send to the 3 countries. The personal protection equipment has already been purchased, but it will be dispatched directly from WHO to the countries. It will not come to South Africa. Thank you.
Okay, thank you very much, Udani. For those of us who can still manage to throw in something in the mouth,